Hi, I'm Matt Binnicker, the Director of Clinical Virology and Vice Chair Practice in the Department of Laboratory Medicine and Pathology at Mayo Clinic. Transfusion of cryoprecipitate is used for patients who are in need of fibrinogen replacement and occasionally for inherited disorders. In this month's Hot Topic, my colleagues from the Component Laboratory in the Division of Transfusion Medicine will discuss a process improvement that helped to decrease the standard cryoprecipitate dosage and the positive impact on patients. I hope you enjoyed this month's Hot Topic, and I want to personally thank you for allowing Mayo Clinic the opportunity to partner in your patient's healthcare.
Hello, we are Jessie Swanson
and Michelle Soland,
here to talk to you about the secrets of cryoprecipitate, a blood banking process improvement. The objectives of this presentation are: what is cryoprecipitate? Discuss product storage and requirements for manufacturing. What are some indications for use? Defining the standard dose, and describe the process improvement of cryoprecipitate in detail. What is cryoprecipitate? Cryoprecipitate, often called cryo, is a frozen blood product prepared from fresh frozen plasma. It is comprised of cold insoluble proteins that precipitate when fresh frozen plasma, also called FFP, is thawed. It is rich in plasma proteins such as factor VIII, fibrinogen, factor XIII, von Willebrand factor, and fibronectin. One of those components, factor VIII, is also called antihemophilic factor, or AHF, which is why cryo is sometimes called cryoprecipitate antihemophilic factor, or cryoprecipitated AHF. Pictured here is a thawed cryoprecipitate pool ready for transfusion. They range in color from pale to dark yellow and can even appear as an even, thick, whitish liquid. On a history note, current cryo use is far removed from that which it was originally intended. Let's have a broad overview of how cryoprecipitate is manufactured. Cryo is manufactured from fresh frozen plasma collected from whole blood donation. Fresh frozen plasma is plasma frozen within 8 hours of collection. Why is freezing plasma within 8 hours significant for making cryo? Research has shown the amount of liable factors degrades over time prior to freezing. FFP of the same ABO is slowly thawed at 1 to 6 degrees Celsius until a slightly slushy consistency is achieved. This can be done by thawing in a refrigerator for 18 to 24 hours or a few hours in a circulating water bath. Here we have an FFP pulled from a water bath. Circled are the precipitates that are visible prior to centrifugation. They are opaque white in appearance. Once the plasma is thawed, the liquid plasma is separated from the cryoprecipitate by centrifugation, utilizing a heavy spin. This is done to concentrate the precipitates to the bottom of the bag. The precipitates will have a thick white to opaquish consistency. It can be mistaken as a fibrin clot. After centrifugation, the supernatant is removed by gravity drain or plasma expressor. Approximately 10 to 15 mils of supernatant plasma remains with the cryoprecipitate, and it is used to resuspend those precipitates. At this point, the cryo may be refrozen immediately or pooled. Pictured on the left is a single cryoprecipitate containing approximately 25 to 30 grams of supernatant and the precipitate pellet. Circled are those factors. The supernatant plasma pictured on the right can be refrozen as a transfusible product called cryopore plasma or as a non-injectable product called recovered plasma. Both cryopore plasma and recovered plasma are deficient of those cryo factors. Cryopore plasma is an injectable product that is typically used for plasma exchange. Recovered plasma is an unlicensed product that can be shipped to manufacturers of plasma products. To create a pool, single cryo are welded onto a pooling harness set. The process of welding is sterile and allows the product to be a closed system. The single cryo are pooled to provide a single, combined, therapeutically effective blood product, a cryoprecipitate pool. Pictured is a 5-unit pool. Now let's discuss the storage and shelf life of cryo. Cryoprecipitate is stored at negative 18 degrees Celsius or colder and has a shelf life of 1 year. For pooled cryo, the expiration date is determined to be 12 months from the earliest date of FFP collection. To prepare cryoprecipitate for transfusion, it is thawed quickly at 30 to 37 degrees Celsius and then stored at room temperature, 20 to 24 degrees Celsius. Thawed single cryo and pooled cryo, which are sterilely manufactured, have a shelf life of 6 hours. Currently thawed cryo cannot be refrozen or refrigerated due to regulatory standards. Fun fact, refrigeration causes factors to reprecipitate, making it unsuitable for transfusion. Each cryo product has to meet regulatory agency requirements. The Food and Drug Administration requires cryo to be quality control tested on at least 4 representative containers each month. Each unit must contain a minimum of 80 international units of factor VIII and a minimum of 150 milligrams of fibrinogen, times the number of units in the pool per AABB standards. For example, Mayo Clinic Rochester manufactures pools of 5 units. Therefore, the QC values we need to pass are greater than or equal to 400 international units per pool of factor VIII and greater than or equal to 750 milligrams per pool of fibrinogen. Cryoprecipitate was originally prepared as a source of factor VIII for hemophilia A patients and to treat patients with von Willebrand's disease. It is no longer the preferred product for treatment of hemophilia A and von Willebrand's disease, as coagulation factor concentrates are readily available. Patients that benefit from cryoprecipitate are typically patients needing fibrinogen replacement when clinical bleeding has occurred, and individuals with disseminated intravascular coagulation, or DIC. Occasionally, cryo is transfused for inherited disorders of fibrinogen and uremic bleeding. Another indication for cryo is during a massive transfusion, in which it helps to maintain hemostasis due to postpartum hemorrhage and surgical cases such as cardiac, gastrointestinal, transplants, or trauma incidents. Just like other blood products, it is subject to misuse. Common misuse of cryo is reversal of warfarin therapy, replacement therapy in patients with normal fibrinogen levels, and treatment of bleeding without evidence of fibrinogen deficiency. It can also be underutilized in massive transfusions with dilution, coagulopathy, and bleeding. When choosing cryoprecipitate for transfusion, cryo should be selected as ABO compatible. In some instances, large volumes of cryo may cause a positive direct antiglobulin test and mild hemolytic transfusion reactions. This can be caused by the isohemoglutins anti-A and anti-B. However, cryo can be administered regardless of RH. This is due to the fact that neither plasma nor cryoprecipitate contain red cells. Compatibility testing is also not required. Transfusion of cryoprecipitate carries the same risks as plasma transfusion. Potential risks and adverse events such as infection, viral or bacterial, volume overload, and transfusion reactions. Cryoprecipitate has a lower risk of causing hemolytic transfusion reactions than plasma because of the smaller volume administered. Cryo is administered utilizing aseptic technique through a filter designed to remove clots and aggregates. Transfusion is started before cryo expires and completed within 4 hours. The standard adult dose of cryoprecipitate at Mayo Clinic Rochester is 10 units or 2 pools, with each pool containing, on average, 277 milligrams per unit or 1,389 milligrams per pool of fibrinogen. External suppliers such as the American Red Cross provide blood products to other Mayo campuses. These sites are producing cryopools of 5 units at dosages greater than 300 milligrams per unit or greater than 1,500 milligrams per pool. This allows for other Mayo campuses to drop their standard dose from 10 units to 5 units. Mayo Clinic Rochester recognized the need to standardize and improve their concentrations to decrease the patient dose. The goal was to drop the adult dose from 10 units to 5, allowing ordering consistency across all Mayo sites. Now that you have some background information of cryoprecipitate requirements and indications, let's learn about a case study presented by Michelle.
Thank you, Jesse. A middle-aged man underwent a reoperative aorta surgery. This surgery required a long cardiopulmonary bypass run and cooling of the patient to 18 degrees Celsius for a good duration. The patient started to bleed a lot, and like most, the new graft caused depletion of fibrinogen levels significantly. In the end, the patient was transfused 40 units of cryo. That's 5 donors in each pooled cryo. 200 FFP were manufactured into 200 single cryo and were used to create 40 pools. That means this patient was exposed to 200 donors. Therefore, if we benchmarked a process improvement, then this patient could have had fewer products, less donor exposure, and less inventory used on one individual. Now, let's talk about this process improvement project that took place in the component laboratory at Mayo Clinic, Rochester. We experimented 12 different process changes, including, but not limited to, centrifuge settings, thaw rates, and differing product manipulation. Our group also toured other product manufacturers to see their processes. We reevaluated multiple steps in the process, starting with implementing new thawing techniques. Fresh frozen plasma varies in volume due to various donor factors. It is important to thaw them evenly. Even thawing helps prevent some FFP from being completely thawed, while another FFP could be icy in the batch. Too slushy or too icy of a product is difficult to manipulate. To increase this chance that your products will thaw evenly, the process is now defined to choose FFP that are within 20 grams of each other. We defined a desired consistency of thawed FFP. For best recovery, they should be thawed to a slushy or slightly slushy state, therefore impacting factor 8, as it is a temperature-sensitive product. We also defined thaw time in the water bath. As a reminder, cryoprecipitates are cold-insoluble proteins. Therefore, it is important to closely monitor thaw. We implemented this by checking the FFP at approximately 1 hour, 30 minutes, and adding additional time as needed. When checking the products, keep manipulation of the product to a minimum. We don't want to resuspend factors prior to centrifugation. Heat is also an important factor that can be negatively affecting the recovery. Next step we investigated was centrifugation. Factors such as time, speed, like RPM, and brake settings alter the force applied to the precipitates. We also investigated the fact, since we have a chilled centrifuge, we should also chill the cup liners to prevent further unnecessary heat transfer. Here in the component laboratory, we have access to 2 different centrifuges for manufacturing, so it is also important to have the settings match each other. As a result of testing, we increased RPM, time, and adjusted brake settings for both centrifuges, allowing products to spin faster and longer to get the most precipitates collected to the bottom of the product bag. The next change was looking at separation of cryoprecipitates and byproducts. Previous manufacturer's separation of cryo was by inversion and draining. We noticed any free precipitates that did not get compacted into a pellet would drain into the supernatant. To counterbalance this, we created a shelf. The spun FFP would lie on the shelf and gravity drain horizontally. This helps prevent the free precipitates from draining and instead stay in the precipitate bag. We further emphasize keeping the product cold by laying the precipitate bag on top of coolants on a raised shelf while it's draining. We increase single cryo weight to 25 to 30 grams with an optimum of 28 grams. This helps ensure we are only adding 10 to 15 milliliters of supernatant to resuspend the precipitates prior to pooling. Increased weight also aided in removing all of the precipitates from the product bag. The next process we reevaluated was pooling. Pooling ensures 5 single cryo are sterilely connected without being exposed to air contaminants. This video shows the process of connecting a single cryo to a pooling set. This instrument works by placing tubing from 2 separate products into a clamp. Then a wafer is heated. This slices the tubing while maintaining sterility and welds them together without any contamination. This process is repeated until all 5 single cryo are connected to the pooling harness set. Changes to the pooling process include the use of a scraper, no rinsing, and reducing heat transfer. The second video shows the process, which implemented the use of a scraper to mix the cryoprecipitates and plasma. Using a scraper, each single unit is scraped and mixed until the precipitates are resuspended as shown. Then we visually inspect each bag. This is done to ensure there are no precipitates stuck to the product bag. If precipitates are found, further mixing with the scraper is required. The single cryo are then drained by rolling into the pooling bag. This process is repeated for all 5 single cryo units. The implemented process also advises no rinsing of the products unless there are precipitates that need to be further mixed and put into solution. This further reduces manipulation of the product between bags and prevents loss of product in tubing lines and product bags. The previous manufacturing process required manual manipulation with our hands. Resuspending the precipitates was done by massaging the single cryo with our hands. Therefore, the new process of using a scraper for mixing reduced hand heat transfer. The precipitated factors are greatly affected by temperature, as exposure to excessive heat will significantly decrease the efficacy of the final product. As you see in the video, we now roll the bags empty to make sure all the products are removed from the individual bags into the pooling harness set bag. Excess air is expressed from the final bag to prevent bag breakage when it is frozen, and the pooling bag is then heat sealed off, thus creating a 5-unit cryo pool. The new manufacturing process was validated to an increased average fibrinogen of greater than or equal to 1450 milligrams per cryo pool and was implemented November 5th of 2018. Part of the ongoing process improvement, we are continuing to monitor our results since implementation. Pre-intervention of our Factor 8 average results were 823 international units per pool. Post-intervention of Factor 8 average results are 782 international units per pool. We are not as concerned about this decrease because it is still well above regulatory requirements. Cryoprecipitate is not typically used for the treatment of Factor 8 deficiencies because Factor 8 concentrates are readily available for use. However, these values will continue to be monitored. Pre-implementation fibrinogen average results were 1,389 milligrams per pool. Post-implementation fibrinogen average is now 1,574 milligrams per pool. In conclusion, the process improvement will help standardize the cryoprecipitate dosage and benefit the patient, as the needs of the patient come first. The process change led to decreasing adult standard dose of 2 pools to 1 pool per transfusion. Furthermore, it reduced donor exposure from 10 donors to 5 donors. Exposure to multiple donors creates an increased incidence of transfusion reactions and potentially a higher risk of disease transfer. The process change might also increase inventory, which is especially helpful when cryo usage is higher than normal. It could also be potentially cost-saving for patients, when they would only pay for one cryo pool and a shorter transfusion time. With continual monitoring and potential improvements, the dosage change was recently effective. To summarize what we presented, cryoprecipitate is cold insoluble proteins that precipitated from fresh frozen plasma. Frozen cryo is stored at negative 18 degrees Celsius or colder and has a shelf life of 1 year. Thawed cryo is stored at 20 to 24 degrees Celsius. A closed system cryopool has a shelf life of 6 hours. Indications for use are for patients needing fibrinogen replacement and occasionally inherited disorders. Standard dose is now 5 units of single cryo, or 1 cryopool. We hope you enjoyed the presentation. Here are our references for your prospective process improvement ideas and educational reading. We hope you found this presentation informative.